Now, my topic for today, I was asked to talk about FSHD, Facioscapulohumeral Muscular Dystrophy, and Myotonic Dystrophy, and I thought I'd talk about management as it is at the present time and try and point the way to the future. And fortunately, Sam's done a lot of preparing the way for me, talking about splicing. Good. Right, now myotonic dystrophy is where we'll start. This is partly because I've just recently been to the World Congress of Myotonic Dystrophy in Sweden, and a new set of guidelines were brought out at the meeting, so a lot of that will be addressed in the talk today. One recent interesting bit of information is that myotonic dystrophy is actually a lot commoner than we thought it was. What they did in New York State was look at newborn blood spots and actually try and work out how many people, based on consecutive newborn blood spots, had myotonic dystrophy. And it worked out about 1 in every 2,500 people have the genetic makeup of myotonic dystrophy. A lot of them will not develop it until very late in life. Now, myotonic dystrophy differs from other muscular dystrophies. Patients have myotonia, stiffness, and failure to relax their muscles. Distal muscles, that's the hands and the ankles, are affected rather than with most muscular dystrophies, which we call limb girdle, which affect the shoulders and the hips. It's a multi-system disorder, so it doesn't just affect muscle, it affects brain, eyes, heart, gut, endocrine, and immune systems, in fact, pretty much anything you can think of. And an onset may be at any time from birth through to late life. In fact, it may start before birth with reduced fetal movements. And there are two forms, DM1 and DM2, myotonic dystrophy types 1 and 2. We call it DM from the original Latin Dystrophia Myotonica. If we called it MD, we're going to get confused with all the other muscular dystrophies, so it tends to be called DM. So briefly, the genetics: it's an autosomal dominant disorder, so if a parent has it, each child has a 50% chance of inheriting it. We'll come back to this a little more later. DM1 is due to an unstable trinucleotide repeat sequence, and we've heard about the 3 nucleotides that each code for a protein, but this is a sequence of CTG. It's in an untranslated region of the DM protein kinase, DMPK, on chromosome 19. And DM1 subjects have more than 50 repeats, and this may go up to many thousands. So repeat numbers vary between organs, so different organs and different people are affected differently. The heart may be affected more than the skeletal muscle. Endocrine system may be affected more. Repeat number varies between organs, and it also increases with life, which makes it a progressive disorder. It shows what we call anticipation. This means that there's a reduced age of onset or increased severity in successive generations. So the children tend to be more severely affected than their parents, and this is due to an increase in the size of the repeat expansion. It increases a lot more in women than it does in men. So in the female germline, the expansion can often increase quite markedly, and this can lead to congenitally affected babies affected at birth, born to mothers who are minimally or not affected. So it's not uncommon for a parent not to know that they have the disorder until they produce an affected child. Congenital DM1 present at birth is the most severe form, and these children are floppy at birth. They have club feet and other deformities, poor sucking and swallowing, and they often need respiratory support. They have delayed motor and mental development. They may have fecal incontinence, and they often go into cardiorespiratory failure relatively early in life. And these children are born to mothers. Congenital children are very, very rarely born to fathers. And as I've said, the mothers may be asymptomatic, unaware that they have the disorder. This is one of the reasons why genetic counselling becomes so important in myotonic dystrophy, and we're going to deal with this topic a bit later. This is a child with congenital muscular dystrophy. As you can see, they're newborn. They're already on ventilatory support and being fed. This is one of my patients from many years ago. This is a congenitally affected baby with the mother who was only diagnosed at the time that the baby was born. As you can see from the baby, they have a fairly characteristic face with a high tented lip. If you look up at the mother, I guess you probably can see some early signs of myotonic dystrophy with a high tented lip and droopy eyelids. These all come from a different country. Any slides that you see go back to when I practiced in New Zealand, so I'm not too concerned about presenting them here. And all of them are sorry. All of them are about 40 years old. Then there's childhood onset DM1, where the patients often present with facial weakness, indistinct speech, grasp myotonia. This is holding on to things and then great difficulty letting go is very prominent. They have learning difficulties, heart involvement, and there's less parent of origin effect. In adult DM1, the patients may present with features other than muscle weakness or myotonia. So there are a whole range of things that people can actually present with. These can be the first symptoms: cataracts, dysphonia, difficulty with their speech. The speech is often rather nasal and difficult to understand. Irritable bowel, fatigue, sleepiness, irregular heartbeat, testicular atrophy, cognitive problems, behavioural disturbances, or, as I've said previously, even presenting because a severely affected child was born. Now, DM1 in an adult is a slowly progressive, predominantly distal, that's hands and ankles. The weakest muscle in the body is the muscle that actually curls up the tips of the fingers, so these people have a lot of difficulty manipulating things and lifting heavy weights. Neck flexors are weak, face weak. As time goes on, people often have difficulty with chest infections, difficulty swallowing, difficulty with their heart. They have heart irregularity, heart failure, problems with sleep, not breathing properly during sleep, benign skin tumours, pilomatricomas. Diabetes is common. It's not severe diabetes, but it needs treatment. Thyroid dysfunction is common. So there are a lot of things that need to be looked at and followed. This is just to look at typical myotonic dystrophy. There's a number of features: frontal balding, droopy eyelids, often loss of the temporalis muscle, and a relative loss of musculature around the neck. So there's a rather characteristic appearance. It's a slowly progressive disorder. Maybe muscle weakness increases by about 1 to 3% per year. There's weakness and atrophy of the jaw and facial muscles, so facial expression tends to be reduced. The eyelids may start drooping. There can be weakness of the tongue, weakness of the palate, and this is what gives the indistinct speech. These people can be difficult to understand. Chewing can become difficult and swallowing difficult, both because of weakness and also stiffness in the muscles, myotonia. Patients may have difficulty holding up the head, and in a car it's important to have proper headrests to prevent easy whiplash injuries. Abdominal muscles are often weak, so people get rather bulging abdomens. It's often not due to overweight, it's due to weakness of the abdominal muscles and not holding things in. The diaphragm can be weak, causing difficulty breathing, and all this impacts their ability to do normal activities of daily living and limits their options in terms of employment. Now, management of muscle weakness, what do we do? Now, it's important, exercise really does help people, and there are good studies to show that low to moderate intensity aerobic exercises And low intensity resistance, by aerobic I mean things like walking, rowing machines. Resistance is more light weights, and minimising sedentary activities if possible help. I'm keen to get people into a heated pool doing hydrotherapy. If they're going to start a new exercise program, probably the heart should be checked first to make certain that it's safe. In order to get round some of these problems, a lot of patients will need assistive or adaptive devices such as orthoses to prevent the ankle from dropping and from rolling over. Canes, walkers, hand splints all need to be considered. Home modifications, environmental modifications when they're necessary, things like rails, ramps, showers that have no hobs, bathrooms where there's adequate space and rails, toilets that you can get up and down from, stairs that are appropriate, get rid of the carpets, get rid of all the junk that's lying around on the floor, make life easy. So I try to get my patients involved in a rehabilitation program formally where all these things can be looked at. Now let's go to myotonia, because this is a almost constant feature of myotonic dystrophy. This is sustained contraction of muscles, difficulty relaxing muscles. And I've had patients present because of problems with this. Many years ago, I had one person present because they were trying to bulldog a calf and couldn't let go of the horns. I've had someone else who was on a building site and grabbed hold of a hawser as it went past, couldn't let go and swung out over the building site, but fortunately got back on again. So it can get you into trouble. The myotonia is worse in cold. It improves with repeated activity. So I try to get people to stay warm, wear gloves. We can use medications if necessary. Mexilatine is my go-to medication for this. We need to get a cardiogram first, make certain that it's safe to use, but it can be effective. I use it particularly in patients who have trouble with speech and swallowing as a result of their myotonia. We'll see if we can, I'm not sure whether this will play or not. That was some myotonia for you, but I don't think we're going to win. Cardiac involvement's very important in this disorder, and I really put it at the top of the list. So myotonic dystrophy affects heart muscle, and it especially affects the electrical conduction pathways in the heart and causes irregular heart rhythms. Now these can be dangerous because the heart can go into a potentially very dangerous rhythm. Patients can lose consciousness or worse. So symptoms that I look for in all my patients are lightheadedness, fainting, palpitations, that's irregular heartbeat, the feeling that the heart's racing or skipping beats, shortness of breath, chest pain, and there's a small risk of sudden death from cardiac arrest. So we want to know that there are heart problems early. So patients with sudden onset of heart symptoms need urgent evaluation. So I tell all my myotonic patients if they have new symptoms, they need to let someone know immediately, same day. How do we investigate these people? Routine ECG. Most patients with myotonic dystrophy, we get a Holter monitor. That's a 24-hour heart monitor that you carry around outside. It can be picked up or delivered to you in the home, carried for 24 hours. You can do your work, whatever else, and just monitoring the heart to see what irregularity there is. Echocardiogram we do relatively frequently, maybe once a year, maybe less frequently. And if patients have symptoms, we can't work out what's going on, there's cardiac electrophysiology where a catheter is put into the heart to look at the electrical activity actually inside the heart to stimulate the heart and work out if it's working normally or not. So I advise all my patients to get regular review by a cardiologist who knows about myotonic dystrophy, usually yearly. And I have one cardiologist who's been very interested in this for a number of years and spends a lot of his time actually looking at people with myotonic dystrophy. We've written up guidelines for the management of heart disease in myotonic dystrophy. There are medications that we can use to prevent or reduce cardiac enlargement and loss of function. These are particularly beta-blocking drugs that can slow the heart, take the load off the heart, help it reduce size, ACE inhibitors which help it to remodel appropriately. A lot of patients will go on to need pacemakers and defibrillating pacemakers if there are significant irregularities that need defibrillation. The second very important part of looking after myotonic dystrophy, and we can really extrapolate a lot of these things over to Duchenne dystrophy and many of the other dystrophies, is respiratory management. A lot of patients become short of breath, they have ineffective coughs, they have difficulty lying flat because the diaphragm doesn't work well, and patients can be very susceptible to chest infections. So the breathing problems are the result of muscle weakness, often the diaphragm. Also muscle stiffness contributes to this. So there's poor chest wall musculature, reduced force in breathing, both breathing in and out. This leads to low blood oxygen, an increase in carbon dioxide levels, and this makes people tired and lacking in energy. A lot of patients have impaired breathing at night, so they have poor sleep, they have periods of sleep apnea where they don't breathe properly, and associated with that, often snoring. Patients with this tend to wake up feeling as though they've not slept, they need another night's sleep, often with a morning headache, and then they're drowsy through the day. So it's important to identify this. So what do? We do respiratory function tests to look and see the chest capacities, look at the strength of the chest muscles. We do overnight sleep studies to look for sleep apnea, for low oxygen saturation and a disturbed sleep pattern. Fortunately, we've got very effective treatments. They're not always well tolerated, but they can be very effective. There's continuous positive airway pressure, which is a mask that you wear to increase the pressure within the lungs, and it stops the throat collapsing, it stops the apnea episodes occur, or positive pressure ventilation. And the usual thing is BiPAP, 2 levels of pressure, which help the respiratory muscles to rest overnight and often result in patients breathing much better during the day as well as when they're assisted at night. I want people to be vaccinated for influenza and pneumonia, and again, rapid assessment and treatment of respiratory infections, prevent the problems occurring as quickly as we can. This is a BiPAP machine. The machines are small. The mask can be full face or part face. Most people do get to adapt to the mask. Now, surgery and anaesthesia are a major issue for people with myotonic dystrophy, more so than with the other dystrophies. Patients are more likely than the general population to have adverse effects to medications. They're likely to get depressed breathing, not breathe well when they're given anaesthetics or strong analgesia. If you're going to have an anaesthetic with myotonic dystrophy, and the same goes for the other dystrophies, the anaesthetist must know. You must make certain that the anaesthetist knows that you've got myotonic dystrophy and knows the risks, then you can go ahead safely. But surgery with myotonic dystrophy is not something that can be taken lightly. Even minor operations, if you have a general anaesthetic, need to be done where people really know what they're doing. Why is that? Because cardiac conduction defects can occur during anaesthetic. These could potentially be fatal. If you know that there's a risk, you can be prepared for it and prevent it. Patients often have difficulty breathing after an operation. Most people, when you remove the tube, the anaesthetics stop, they'll breathe normally. With myotonic dystrophy, it may take some time. It may take an hour or more before the patient builds up the drive to breathe properly. So it's very important that they're very carefully nursed through that period. So prolonged and increased sensitivity to sedatives and analgesias are terribly important. Pregnancy is again a somewhat difficult issue with myotonic dystrophy. Mothers with myotonic dystrophy require high-risk pregnancy monitoring, so they need to be done in a high-risk unit. There's an increased risk of ectopic pregnancies or premature deliveries, increased risk of prolonged labour and delivery due to uterine muscle dysfunction and general skeletal muscle dysfunction. Postpartum hemorrhage due to inadequate uterine contractions, retained placenta, reactions to analgesia or anaesthesia during labour. So again, all this needs to be done in a centre that's capable of coping with it. These are not people to have home deliveries. Congenital affected babies, again, we can sometimes predict that before birth, so a paediatrician can be ready, but again, in a high-risk unit, there'll be paediatricians ready to look after that baby when they're born. Most women ultimately do deliver vaginally with myotonic dystrophy. Eye management's important. Patients get cataracts. Everyone in Australia gets cataracts. It's the Australian sun, but people with myotonic dystrophy get them at a much younger age. We monitor people for these, remove them when it becomes appropriate. The droopy eyelids can end up covering your eyes so that you can't see properly, so we have to organise lid surgery for some patients. There's also weakness of eye closure. Not everyone closes their eyes properly, so the eyes often need lubrication at night. So an ophthalmological review is important. Cataract surgery when needed. There are retinal problems that also occur with myotonic dystrophy that need to be monitored for. So eye management is important. This is the Christmas tree cataract of myotonic dystrophy. Gastrointestinal management. People have trouble with chewing, swallowing, have problems with reflux, abdominal bloating, abdominal pain. The gut works slowly, so there's trouble with constipation. Patients may also get diarrhea or even fecal incontinence. So what I recommend is a high fibre diet for patients. If they have diarrhea or constipation, that's the first place to go. Increase fibre intake, increase water intake. I don't mean high sugar drinks. Needs to be something that's not full of calories. Then gentle laxatives if required. Patients may lose weight, may have difficulty swallowing, so it's important to look at their nutrition, and we involve speech pathologists and dietitians. And I've had a few patients where we've actually needed to put tubes into the stomach to feed them. So speech pathology reviews for people with difficulty swallowing. The speech pathologist can work out what the difficulty is. They can work out strategies, ways of modifying the diet so it all goes down smoothly. We want to avoid things going down the wrong way into the chest, which leads to respiratory infection in hospital. Neuropsychiatric management is important. Some adult onset patients do have deficits in what we call executive function. This is a set of processes that involve mental control and self-regulation. It's the way you decide on a goal and get to a goal. Patients often have difficulty with spatial things, knowing quite where things are in space, putting things together. Arithmetic may be difficult, attention may be difficult. So often there are difficulties with organising and planning. Patients also have marked fatigue. Often they're said to be lazy, but in fact they're not. They just tire very rapidly. This affects them both physically and mentally. Hypersomnolence. I've got patients that would sleep for 24 hours in the day if they were given the chance with myotonic dystrophy. Again, this is part of the disorder. It's not laziness. A lot of people get sleep-wake reversal. I'm not certain whether that's tolerable or not, but I frequently find with myotonic dystrophy patients are going to bed at 3 in the morning and getting up at midday or somewhere around about that. And that doesn't tend to fit well with family life. They may require extra support for patients and families and appropriate counselling and medications to help with these things. And again, these things can interfere with employability, social activities and family life. Endocrine management's important. There is an increased risk of diabetes, so we want our people exercising. We want to make certain that they don't put on too much weight and that their diet is good. There's an increased risk of thyroid disorders, and I check thyroid functions, I check blood sugars every year. There's an increase in cholesterol that needs to be checked. So we need to monitor people regularly, and I like to get a full set of blood tests covering those aspects once a year. A lot of people are vitamin D deficient, and in any muscle disease where there's a risk of falling, vitamin D deficiency is going to lead to weak bones and an increased risk of fracturing. So vitamin D levels are monitored, and we need to review those and treat as necessary. Dental crowding is a problem. People with myotonic dystrophies have relatively small jaw, not enough room to get all the teeth in, so often they need special dental surgery. There are dentists who actually specialise in myotonic dystrophy, reorganising the jaw, removing teeth, just getting the dental side sorted out. Now, genetic counselling is terribly important for patients with myotonic dystrophy, and I believe all adult patients should have the availability of genetic counselling through a genetic counsellor or a neurologist with expertise in DM1, someone who knows about it, knows what they're doing. So families need to know and discuss the complexities of the inheritance pattern. They need to know about giving birth to minimally affected children. We need to inform the male and female myotonic dystrophy affected individuals of the possible difficulty conceiving as they get older. Fertility reduces with myotonic dystrophy, so if you are going to have a family, you probably need to do that relatively early and not sort of wait as the current way of doing things is into the late 30s. We need to get mutation carriers, people who know that they have myotonic dystrophy or they're carriers, to let their relatives know the possibility they may have also inherited the risks and the repercussions of DM1, even if they or their children are asymptomatic at that time. And I vividly remember one patient of mine who I'd seen the mother, wasn't a patient of mine at that time, I'd seen the mother who had myotonic dystrophy, who we had made the diagnosis, we'd asked her to inform the family, and she said, "I want no one to know, you're not to tell anyone, that's it." Anyway, the next call I got was from her daughter, who said, "You knew my mother had it. I have a congenital baby. I had no idea." So it's important within families that people know what's going on. Families are often private, and it's often difficult to get this information to circulate. So people with DM1 or at risk for DM1 should be offered gene testing if they're considering having children. Now, we don't want to test young children. We want people to make their own decisions about testing for DM1, so I think it's reasonable that people are tested when they're making life decisions about what employment they want, what work they want to do, whether they're going to have families, and how they approach it. So genetic testing's easy. It's a standard blood test. This is a simple test to do. It's much less complex than something like Duchenne dystrophy. We can avoid patients passing this on using the technique of pre-implantation genetic diagnosis. Now, this is an IVF technique where the egg and the sperm are placed together. They then start dividing, and very early on one cell is taken from the embryo, and it can work out for each embryo whether it does or does not have myotonic dystrophy. The unaffected embryos can then be implanted, and Professor Jones at the back there is the expert on this, not me, so ask her any questions about PGD. We can also do chorion villus sampling early in pregnancy, but this is less acceptable, and again make a decision about retaining a pregnancy or not retaining a pregnancy. I just stress that any decisions made about these things are individual decisions. They're taken by patients and their families, but they need guidance from genetic counsellors. But the decisions remain the decision of the person who's considering the pregnancy. We've heard a bit about inheritance. This is autosomal dominant inheritance, and for each gene we have two alleles, two copies of the gene. With autosomal dominant, if we've got one bad copy of the gene, we have the disorder. Recessive disorder, we need two copies of the gene. We've heard about transcription of DNA into mRNA and then translation of mRNA into protein. Now I'm going to look at this as it's dealt with in myotonic dystrophy. So we have the expanded DNA repeat sequences, and these are transcribed into RNA, but they're not translated into protein. We get these big chains of RNA forming stable hairpin structures. They're trapped in the nucleus of the cell. They're not translated into protein, but these then disrupt RNA processing. They bind a protein called muscle-blind-like 1 protein, and there are a lot of funny names in genetics, and a lot of this comes because a lot of this work was done in fruit flies. And this particular protein's responsible for eyes and muscles, so it's called muscle-blind because the fruit flies that don't have it are blind and weak, so it's muscle-blind like 1. Anyway, in myotonic dystrophy type 1 or type 2, which is a tetranucleotide repeat, end up forming these big chains. They're trapped in the nuclei. They bind muscle-blind type 1. And muscle-blind type 1 is a splicing factor. So it determines how the DNA is chopped up, how the introns are chopped out and the exons joined together. Now, if you've got these are the exons here. If you've got a series of exons, you chop out the introns, the part that don't code for amino acids and proteins. So you can see you can join these up in different sequences, and so you could get a range of different proteins being formed. And in fact, this happens with myotonic dystrophy, and a whole lot of proteins are formed that aren't normal in adult life. Now, how are we going to treat that? So we come back to Sam's, her oligos, the antisense oligonucleotides. And in fact, you can make a shorter antisense oligonucleotide that goes and binds to the repeat sequence and breaks it up and releases the muscle blind, and in fact is very effective at abolishing myotonic dystrophy, and it works extremely well in mice. Now, a lot of things that work in mice don't work so well in humans. So there's been now a phase 2 human trial with ASOs in myotonic dystrophy, but it was relatively ineffective, probably because the oligo doesn't get into normal muscle cells. In Duchenne dystrophy, the muscle cells are disrupted, so Sam's oligos go into the cells, the myotonics don't. So what we need to do is try and adapt these so that they will get into muscle. This just shows you diagrammatically with the oligos binding to the big long chains of RNA and releasing muscle blind and returning things back to normal. So what of the future? So for effective treatment of DM, the therapeutic agent ideally should affect both the skeletal muscle, the heart and the brain. So we're trying to, the search now is to actually join bits to the ASOs that allow them to get into muscle, hopefully allow them to get into heart and brain as well. Although we may have to give them intrathecally. By that I mean putting them into the fluid around the brain to make them effective. There are also CRISPR-based strategies to break this down. That's another technology I won't go into. But also we're looking at there's a lot of interest in small molecules that might release muscle blind. And this is just to show you a diagram of the things that people are thinking about at the moment. So there's a whole range of things. And this is the area that looks most promising in blocking the formation of the RNA strands, and this works well in tissue culture in mice, but it has to be expanded up into people. Right. I'll just quickly go through some FSH now. FSH is another common disorder. I think it's number 3 in terms of frequency. It's stated to be 8 per 100,000, but I think it's a lot more common. Every year when I'm seeing patients for other things, migraines, whatever, I'll pick someone that has FSH. They won't know they've got FSH. No one in the family knows they've got FSH. There are no population screens really looking for FSH, so I think it's quite a common disorder. Onset can be any time from congenital to late life, so there's a widespread spread of severity. Males are often a bit more affected than the women with it and tend to have an earlier onset. Now, unlike almost all other muscle disorders, which are linear disorders, that means that people get slowly worse along a fairly straight line. FSH is asymmetrical, affects the two sides of the body differently, and it's stepwise. So people lose a muscle here, or maybe a muscle there a year later. It tends to affect the face, the scapula or shoulder blade, giving shoulder blade winging, and we'll look at a slide of that. Wasting of the upper arm, the biceps and triceps are more affected. Ankle dorsiflexion weakness, so foot drop. Bulging of the abdominal muscles, weakness of the paraspinal, the muscles down the back of the spine. Patients often sleep with their eyes open because their eyelids are weak. They get dry eyes. They have difficulty raising their arms above their head. They can't comb their hair. They often roll the ankle and trip over due to ankle weakness. Increased spinal curvature, bulging abdomen, waddling type gait due to the hip weakness, and they may have increased retinal vascular permeability, so they're susceptible to retinal detachment. This is the winging of the shoulder blade. You can see how the shoulder blade's not fixed to the chest wall, so when the patient tries to lift the arm up, the shoulder blades come inwards. And in fact, the deltoid, which is the main muscle that lifts our arm up, is strong. It's just that it can't work because the shoulder blade needs to be fixed for the deltoid to be effective. And the face, this again is a patient of mine from about 40 plus years ago. In contrast to Duchenne and myotonic dystrophy, the bulbar musculature, that's the muscles of swallowing and speech, breathing and heart are relatively rare in FSHD, and most patients, other than very early onset patients, onset in childhood, have a normal life expectancy. There are significant physical limitations, and this results in disability, job modifications, and a risk of wheelchair use. And there's quite a bit of clinical variability within families. Now, the big issues for people with myotonic dystrophy are pain. This is a painful disorder. Most of the dystrophies really aren't that painful. People will get pain for various reasons, but with myotonic dystrophy, the muscle does tend to be painful. People get a lot of chronic musculoskeletal discomfort. So a lot of my time is spent trying to treat that. And we use a range of medications from anti-inflammatories through to anti-epileptics, all of which assist with pain. As with myotonic dystrophy, low intensity aerobic exercise, avoiding pain or injury is beneficial. People may need orthotics for ankle stability. Surgical fixation of the scapula can be considered. Occasionally, we do see cardiac arrhythmias and people may require cardiac monitoring. Patients do get this exudative retinopathy. It usually doesn't cause problems, but I've had several people lose vision as a result of that. Eyes get dry, they need lubrication. Hearing loss is a little more marked. It's more of a problem in children where it may interfere with language development. And the question of pre-implantation genetic diagnosis can be raised. We've had a number of children born that way. So just briefly, the genetics of this is quite different. It's caused by a reduction in size of a DNA fragment rather than an increase, but it's the DNA fragment or repeat sequence consists of repeats that are many bases long. They're over 3 kilobases long. with a reduced fragment size is due to deletion of repeat sequences, and it requires not only the reduction in length of this repeat sequence, it also needs to be on a particular chromosome flavour and A haplotype before it will cause FSH. So if we've got a normal number of repeats, we get no DUX4 formed. If we've got reduced number, we get DUX4 formed. And DUX4 causes damage to muscle cells. Now there's FSHD2, which we've not really been able to sort out until very recently, and these have a normal number of repeats, but it's a defect in methylation of DNA. Now, I'm just briefly going to mention this because there's some real hope for FSHD at the moment. The strategies that have been looked at suppressing DUX4 production or blocking the activity of DUX4 protein. And by serendipity, this is just by chance, it's recently been found that medications that are inhibitors of something called mitogen-activated protein kinase, which is part of a signalling pathway that's particularly important in inflammation, is exquisitely sensitive. Well, the DUX4 production is exquisitely sensitive to this, and this stops DUX4 production. And it does so at a low dose that doesn't cause any damage. And also by chance, GlaxoSmithKline have been looking at losopamide, and they've been looking at it for a range of things from rheumatoid arthritis through psychiatric disorders. Doesn't work for any of them, but it's very safe. So GSK have just licensed this to Fulcrum, and the first patients will be entering a trial within probably about now. So this is the first treatment that we've really got that looks as though it'll specifically treat myotonic dystrophy. A final word, we hope to get our registries, which we've hoped to have running properly for a number of years. Hope as the year goes on that will be sorted out with the help of muscular dystrophy, help of FSHD Global. So next year we hope that we'll be able to get people entered in registries and ready for trials. Thank you.